All right, let's jump right in. Today, we're putting on our detective hats to tackle one of the trickiest and, honestly, one of the most important mysteries in geriatric medicine: medication management. We're going to use a really powerful framework called the 4Ms. That's medication, mentation, mobility, and what matters, to guide us as we investigate how to prescribe more safely for our older patients. So let's get started. When you see a lineup of pill bottles like this, it's so easy to just focus on the prescriptions, right? But we have to remember, behind every single one of these bottles is a person, a patient with a life, with goals, with a whole story. Our job, our mission, is to see past those labels and make absolutely sure that what we're prescribing is actually helping, not harming, the very person who's trusting us with their care. And believe me, the stakes here could not be higher. The evidence is just overwhelming. Inappropriate prescriptions are a huge threat. They lead directly to adverse drug events that end up causing hospitalizations that were completely preventable. This isn't some abstract concept. This is happening every single day in our clinics and hospitals. Okay, so here's our game plan for today. First, we're going to dig into the polypharmacy problem to see just how big it is. Then, we'll uncover the main way this causes harm, something called the prescribing cascade. After that, we'll profile the usual suspects, the high-risk medications we see all the time. We'll get our hands on some detective tools for deprescribing, and then we'll put it all together to solve a real-world case. First things first, we have to understand the scene of the crime, so to speak. And the central issue we're looking at is polypharmacy. You might be surprised by just how common this is. So, what do we even mean by polypharmacy? Well, the definition is actually pretty simple. It's just the routine use of 5 or more medications. And that includes everything: prescriptions, over-the-counters, even supplements. Now, 5 might not sound like a crazy number, but that's the magic threshold where the sheer number of medications starts creating a really high risk for things to go wrong, events that can directly mess with the patient's thinking, their ability to move around safely, and ultimately their independence. And this chart, wow, this really puts the scale of the problem into perspective. Just look at that first bar. A full 40% of adults over 65 are taking between 5 and 9 medications. Then look at the next one. Another 18% are taking 10 or more. If you do the math, that's nearly 60% of older adults who fit the definition of polypharmacy. This isn't some small issue. It's a full-blown public health epidemic. So you might be asking, how in the world do patients end up on so many medications? Well, it's almost never one single thing. It's more like a slow creep over time. A blood pressure pill started in their 50s just never gets reevaluated. They see a bunch of different specialists, and each one is focused on their own little world, with no one acting as the quarterback for the whole medication list. And of course, there are those standing orders from a hospital stay that can literally follow a patient for years, with nobody ever stopping to ask, hey, do they still need this? So we've established that patients are on way too many medications, but how exactly does that lead to harm? This brings us to the classic modus operandi of medication-related problems: the prescribing cascade. The prescribing cascade is this really nasty, vicious cycle. It all starts when a side effect from one drug gets mistaken for a brand new medical problem. So, instead of stopping the drug that's causing the issue, what happens? Another medication gets prescribed to treat that side effect. And guess what? That new drug can have its own side effects, and the cycle just keeps going and going and going. And this diagram just perfectly illustrates that dangerous feedback loop. You have an illness, you get a medication, but that causes an adverse drug event. That event is then misdiagnosed as a new illness, which leads to another prescription, and a cycle just spins and spins, often with really devastating consequences for a patient's mentation and their mobility. Okay, so now that we get the mechanism, it's time to profile the culprits. In geriatric medicine, there's a pretty well-known list of usual suspects. These are the medication classes that are constantly showing up at the scene of the crime when it comes to adverse events. Suspect number 1 is a huge one: the anticholinergics. This category is huge. We're talking about common over-the-counter stuff like Benadryl, muscle relaxants, even some meds for incontinence. Their calling card, their MO, is messing with the brain. They cause confusion, delirium, and memory loss, which is a direct hit on the mentation M. They can even make underlying dementia worse. Our next suspect is pretty infamous for its use in treating anxiety and insomnia. And this image just captures that feeling perfectly. I'm talking about the benzodiazepines. Now, while they might seem like a quick fix for sleep, they come with a really hefty price tag. They dramatically increase the risk of falls and hip fractures. They can cause dependency, which can really interfere with what matters most to a patient, their autonomy. They can contribute to dementia, a direct blow to mentation. And the real irony, they actually reduce the amount of deep, restorative REM sleep, so patients wake up feeling groggy and unrested anyway. And we really cannot overstate the danger of falls. This right here, this is the real-world consequence. A single fall can be the event that takes someone from living independently at home to needing a nursing home. And that just changes their life forever. This is a massive threat to the mobility M. Suspect number 3, antipsychotics. These are being used more and more off-label to try and manage agitation in patients with dementia. But they come with huge risks. They can skyrocket the risk of falls, threatening mobility. And they can actually make cognition worse, which impacts mentation. There's a reason they have a black box warning about an increased risk of death. The much safer approach often involves focusing on what matters to the patient and trying non-drug behavioral strategies first. And our final suspect might just be the most surprising of all, mainly because it's one of the most prescribed types of medication on the entire planet, proton pump inhibitors, or PPIs. The most shocking fact about PPIs, up to 70% of prescriptions for them don't have a clear evidence-based reason. They just get started in the hospital for stress ulcer prophylaxis and then never get stopped. And the long-term use is linked to this really frightening list of problems: C. diff, hip fractures that can shatter a patient's mobility, and even a potential link to dementia, which would be a catastrophic blow to their mentation. So, we've profiled our suspects. Now the big question is, how do we fight back? This section is all about arming you with the detective's toolkit for what we call de-prescribing. That's the systematic process of stopping or lowering the dose of medications that are inappropriate. Here are your key strategies. First, do a brown bag visit. Have the patient bring in everything so you get a full picture of the first M, medications. Use screening tools to hunt for drugs that might be harming mentation or mobility. Team up with your pharmacists. They are your absolute best friends in this fight. And this is a big one. For every single drug on the list, you have to be able to link it to a diagnosis. If you can't, it's got to go. And all of this work serves the most important M of all: what matters. Does this medication list actually help the patient achieve their life goals, or is it getting in the way? And one of the most powerful tools you have in your kit is the American Geriatric Society Beers Criteria. Think of it as an evidence-based, most wanted list. It explicitly names potentially inappropriate medications, we call them PIMS, in older adults. It gives you the clear rationale for why a drug should be avoided, which makes it an absolutely essential resource. Okay, this is it. It's time to put all the pieces together. We've learned the concepts, we've got our tools. Now let's apply everything we've learned to solve the case of a patient named Mr. George Kaplan. So meet Mr. Kaplan. He's 84, and as you can see, he's got a pretty complex medical history. But I want you to focus on the new clues here. His mentation is off. He describes it as foggy thinking. His mobility has been compromised. He's already had a fall. These new symptoms are a direct threat to that fourth and most important M, what matters to him: staying in his own home, tending to his garden, and keeping himself out of the hospital. So now it's your turn. You're the detective on this case. Look at his symptoms through the lens of our framework. His mentation is foggy. His mobility is clearly at risk. Which of the medications on his list are the likely culprits? Which ones are setting off a prescribing cascade that is now threatening the thing that matters most to him in the world? All the clues are right here. The only question left is, what are you going to do about it?